Today, I am pleased to introduce our guest speaker, Dr. Tim Pletcher, who is a former expert in health informatics, advanced analytics, data science, and learning health systems. Prior to his current post as the Executive Director of the Michigan Health Informatics Network Shared Service, he was the founding director for the Institute for Health and Business Insight at Central Michigan University that provided high-end data science services to Fortune 500 companies and large organizations such as Dow Chemical, General Motors, Harley-Davidson, and a huge list that I will not be able to include all here, to extract insight and value from their data using business intelligence and predictive modeling. Tim started his career in the University of Michigan's College of Engineering, where he built advanced data networks, and was later recruited to the medical center to develop the Health Science Network. Subsequently, at the Consortium for International Earth Science Information Network, Tim worked in Washington, D.C. on the NASA Earth Observing System Data and Information System project, supporting a federal interagency working group on data management for global change networking activity in the CDC, UN, World Bank, and the WHO. After returning to the University of Michigan from Washington, D.C., Tim led an advanced technology group and served as a director for research and business information systems at the University of Michigan Health Systems. His advanced technology group focused on linking research to clinical practice for efforts like telehealth and simulation. In 2000, Tim and the Medical Readiness Trainer Project team members at UMHS received a Smithsonian Computer World Medal for utilizing virtual reality and computer-based modeling and human patient simulation to reduce medical errors. He received a doctorate of health administration and a master's degree in health administration from Central Michigan University, and received his Bachelor of Science from the University of Michigan. Please join me in welcoming Dr. Tim Pletcher.
So I apologize for holding this. I'm recovering from a short cold, so my voice isn't as strong as it sometimes is. If for some reason as I taper off in a conversation you can't hear me, please in the back let me know, and I promise I'll be louder. Once again, I'm Tim Pletcher. I'm the Executive Director for the Michigan Health Information Network. I also hold an adjunct faculty appointment in the Department of Learning Health Sciences under Dr. Chuck Friedman. And I'm here on Wednesdays. So this is a Tuesday, so I'm here a couple times this week. And I'm really excited about the learning health system concept. And if any of you are familiar with Dr. Chuck Friedman's work on the learning health system and a lot of his discussion about infrastructure, lately my work at MiHIN has led me to describe myself as a practicing infrastructuralist, meaning I'm trying to build infrastructure in the state of Michigan. And MiHIN is a nonprofit organization. It's a quasi-government organization, meaning it's a nonprofit, private organization, but it's heavily influenced by representation from folks within state government as well as some of the public commission. And it's set up to achieve motherhood and apple pie in healthcare, but probably the most interesting thing is really overall improving the liquidity of information and its flow across the entire state, and doing that in a way so that that information can flow to the point of care, wherever that point of care is. And increasingly, as patients take more role in their own health care, and as mobile becomes an opportunity for the point of care to go just about anywhere, we're trying to establish the infrastructure so that it can follow people and can follow that point of care wherever it ends up. And that's a little bit different when you think about scale than traditional health enterprises. Some people refer to this space as health information exchange. We abandoned pretty early on the concept of calling ourselves a health information exchange and have favored ourselves pretty much as a network of networks, or we'll say the focal point for integration for the state, or we'll say enabling an ecosystem. And the basic concept is MiHIN is really not a place you can log into. It's not a repository of all the medical information. It's really the set of interfaces and services and master data to enable communication to happen on a statewide basis. And we typically say that we're responsible for 3 basic pillars: legal connectivity, technical integration, and a lot of the cybersecurity type components of protecting the infrastructure. Those are sort of 3 foundational elements that are really in this ecosystem. And in this ecosystem, we serve as a single point of entry for state government, in particular for the Michigan Department of Health and Human Services, but increasingly some of the other departments. DHHS at Michigan is roughly 45% of state government, so it's all of the social programs. Every single health plan in the state of Michigan is basically part of MiHIN. We have connectivity into the federal infrastructure, whether that's through the Sequoia project or some interactions with the Commonwealth space. We have direct connections to a handful of the organizations like the Michigan Health and Hospital Association, where they're the curators of the Michigan Inpatient Database. We have lately started getting more what we call consumer qualified organizations. These are organizations that are offering an untethered personal health record type tools. And we're very, very slowly adding some of those, which I'll talk about later. We have 12 official health information exchanges in the state of Michigan. We connect all of those. We made a pretty aggressive push into the retail pharmacy space. And so increasingly we're picking up more and more of the pharmacies. And we're really bringing these organizations together under sort of a common way to share information. And I promise I won't talk too much about infrastructure, but if you look at these 2 pictures, the question that I would ask you is, do the consumers in both settings get electricity to turn the lights on? And the answer is yes, they do. Okay? So the system works. Which would you rather have? And the question is why? What makes this picture better? Is it just that it's more money? Or are there characteristics of the infrastructure that fundamentally are more enabling than this other picture? And what we're trying to do in Michigan, and I think have successfully done over the last 6 years, is create data sharing capability that looks more like this picture over here, which is a lot easier to debug, easier to maintain, a lot more transparent to what's going on, and consistent with what the rules are and who's paying and sort of how all the pieces fit together. And I'm going to talk about that story, and then I'm going to talk about where we're going. If time allows, I'm going to go into, at the very end, to talk about our persona library and something we call Patient Gen, which is a tool that we built to simulate data so that we can accelerate onboarding and testing and everything from user interfaces to validating security and procedures. So we're the curator of this statewide ecosystem, and we're really trying to identify what's the master data, what should be shared on a statewide basis. Not everything needs to be shared. Possibly not everything even needs to be interoperable, which is heresy in many circles. But there are some things that absolutely need to be done on a statewide basis, and they need to be done at a high standard. And to figure that out, you have to formally convene people and orchestrate governance processes and some of the social, so it's not just technical, but there are social technical interface points where you need to make the storyline work to achieve sort of the end goal. And we've established a process to do that. And as I talk more about the Use Case Factory, I'll explain that. The governance structure in Michigan is there's a thing in Michigan called the Health Information Technology Commission. The governor appoints people to it. It's formally created by legislature. It's a public forum. They meet monthly. They give formal advice to the Department of Health and Human Services and the Department of Technology Management and the Budget. MiHIN is officially monitored by this group, but we don't report to it. So every month I get the privilege of standing in front of these folks and talking about what we're doing and hearing their feedback. And remember, it's a public record, so anything I say is public record at that point. We have a separate board. That board of directors represents the face of healthcare. So you'll see physicians on it, you'll see hospitals on it, you'll see health information exchanges on it, you'll see health plans on it. There's a person from the Health Information Technology Commission, a representative from Medicaid, and a representative from Public Health, all on that board. And then anybody who has signed the right paperwork to become part of our community and is a trusted data sharing organization that's officially qualified gets to be part of our working governance, where there's an advisory council and a series of working groups. It's pretty common in most states for folks to worry about security and to worry about privacy issues, or in our case we have something called the Use Case Working Group, different working groups that feed into this advisory structure. And that is the process where we kind of come to consensus on what to do. When we talk about the legal process and legal connectivity, one of the things that we work really hard on is preservation of the chain of trust. And that means that at no point can information be delivered to somebody who's outside the chain of trust. And this is actually a harder trick than you think when you're trying to really scale data on data sharing on a massive level. And so we really orchestrated a set of legal documents and a way to go about sharing information so that, in this case, a hospital does not need to have an agreement with an independent doctor to allow this doctor to receive the right information. Likewise, we do not need to have a business associate agreement between a health plan and a hospital. And so we've had to orchestrate a mechanism so the information can flow without every time somebody wants to do something for them to sit down and create a data sharing agreement and go through a pretty elaborate process. Okay? And the way we've done that is different than how it's typically done in most states and at a national level. In most states, they have sort of a DURSA, a Data Use Reciprocal Sharing Agreement. It's kind of a one-size-fits-all document. In Michigan, we have a two-tier system. And you sign a big document that's very similar to a DURSA in a lot of ways, but then there's a whole set of sub-documents it's really a two-tier system. The best analogy that I can come up with is we put a master agreement together, and if you're in IT, this will work for you. You put a master agreement together, and then you issue individual statements of work or individual purchase orders against that standing master agreement to do lots of little things that perhaps you hadn't anticipated, but they roll back to the master agreement. What this does is it allows you to move very, very quickly, so you don't have to debate all the little nuances of ways you might share information that you can't possibly contemplate. What ends up happening in a one-tier system is everybody signs the one-tier document, and then they go off in a corner and they re-sign a separate data sharing agreement between the two organizations because they're worried about extra stuff. We solve that by having a two-tier system. The other thing that we do that's a little bit unique is we set these agreements up so you can share data, but also so you can share money. So it actually serves the purpose as a contracting vehicle that's bi-directional, as well as a data sharing vehicle. And this is important because increasingly in the ecosystem, we're moving money around. We want to hire different groups, they want to hire us, and we're able to broker transactions. And as you know, brokering money is a good business to be in. It's all legal. So it turns out that as a public entity, accountable to this public commission, we have to be able to take everybody's ideas in. Everybody's desire to share information is valid, at least at the beginning. And so we have a URL that people can submit an idea for data sharing. But it turns out not all ideas are fungible. And so we have an intake process where somebody submits a conceptual idea for data sharing. What we require is that somebody take that idea and turn it into a couple paragraphs. And it is shocking how few people are willing to put the time and energy into just write 2 paragraphs for your idea. So a lot of things die right there at that conceptual layer. Once they get 2 paragraphs, we kick it into one of the working groups called the Use Case Working Group, and we try to find somebody who's willing to sponsor, let's pay, for this idea to basically have, well, what's the legal stuff need to look like? What technical implementation issues are there? How are we going to pilot this to make it work? And usually a lot of things die right then. But a lot of stuff comes forward, gets built, it's piloted, it's ready to go, it's technology that works, but we've learned that just because the technology works doesn't mean anybody is going to make it a priority to implement in their busy day. And so we have another stage gate, this stage gate down here, and this is a requirement that you now come up with an incentive, some way to pay, or a disincentive or a policy lever, some way to punish, if necessary, folks to adopt this use case and put it into production and get it to the next stage where there's actually people using it. And we learned this the hard way, where we had lots of great technology pieces, lots of good things to do, awesome for the patients, but it turned out people wouldn't implement them. However, when we tied it to an incentive, they got implemented on a massive scale in less than a year. This was shocking. It was shocking to people paying the incentives. We then said, well, let's try tying these, making a set of incentives. Let's make it a requirement for eligibility. And so they put it into the Medicaid contracts that it was a requirement for eligibility for a health plan to be considered a Medicaid health plan on the latest contract if you didn't do certain things. Overnight, they implemented. Okay? So this process is really a way for us to take everybody's ideas but figure out how to really prioritize and focus on the things that we can get done in a timely fashion. Yes?
So at the end of the day, who pays for these incentives?
The people who pay for care or the people who regulate care. So if it's a law and you get punished, it tends to work, okay? If it's an incentive that a commercial health plan wants you to do because they get the benefit of reduced readmissions, then they tie it to their incentives, so like a Blue Cross. Okay? Or it could be the state. The state reaches in and pays for a lot of things as well for the Medicaid population.
I want to have an idea of what is the scale of the incentive?
Great question. Depends on the use case. Hospitals for the statewide ADT use case that I'll talk about in a minute probably get about $1 million and $1.5 million first time. But like all incentives, after time, you kind of push them down, it becomes sort of a given, and then a new incentive shows up, kind of like a sales quota. It never stays the same. But on the order, for a hospital, it takes about $1 million to get their attention.
That goes to the idea with champion?
What's that?
The individual that comes up with the idea?
It doesn't cost them anything. It's free to them. Okay? But at this stage, it can cost people anywhere from $100,000 to $300,000, maybe even higher, depending on the magnitude of what they're trying to do. And then the incentives to get adoption to happen can be millions or hundreds of thousands of dollars to get lots of adoption.
So the groups you showed on the first slide, where you sort of showed all the different types of stakeholders who are participating, can you give us some sense of, like, are those all of the people who are submitting ideas, and are most of them coming from the payers, or most of them coming from the HIEs, or most of them coming from the providers?
They never come from HIEs. They pretty much always come from payers, the state, and then concerned researchers. So we have a great example from U of M related to cancer mammography screening that made it all the way to a really great idea packaged, ready for somebody to sponsor, but we can't find anybody willing to sponsor that use case. So they kind of sit there, and every so often we shop them back around saying, is there anybody willing to kind of birth this use case? Now what's nice about this is then you can begin to look at all these use cases and it creates kind of a pipeline for what kind of capability is coming. And so the ones that are here in green are at an advanced state. We artificially said if roughly 2/3 of all the people who could implement it or have implemented it, that's mature. This blue means it's working. Really does work, you can adopt it. There's incentives out there to get people to do it. The yellow means, yep, technically feasible, being piloted, ready to go. And I only show the conceptual ones that I think are likely to make it across the line, so I don't falsely set expectations for folks. But there are other conceptual ones that people have out there. And it creates a pipeline to sort of move things along. Go ahead.
So how many of these are sort of making electronic what was done manually versus things that just are not being done, period, and are sort of truly new?
So a lot of the public health stuff had varying degrees of, there's a system, somebody went to a website and typed things in. Social Security Administration has a website, you go type things in. Those actually go slower, even though there's money on the table for people, because they get kind of paid your way. All right, and so for some of these, we've taken to convincing the state once they get out of the yellow, to turn stuff off, or to actually declare a sunset date when the alternative mechanism goes away, and that helps people kind of get on board with it.
How have you dealt with the issue that while publicly everybody talks in positive terms about being able to exchange all this information, technically, easily, and everything, given the nature of health networks in the United States, privately a lot of people, in fact, have a disincentive. They want to keep things in the network. And
So-
sort of, I mean, how have you been able to impact that sort of, what we publicly say versus the private reality?
We pay them or we punish them. It's really simple. And then we don't charge providers at this level in the ecosystem, at MiHIN's level. We believe that all of the change that people want to happen is they want providers to make some kind of change in their workflow. And so trying to ask them to pay for the privilege of losing revenue doesn't seem to make sense. So what we do is we try to take the incentives to force people, we pay them, okay? Or we make it a requirement for certain things that they want. That's the only way that we've been able to get people over the hump. When I first went to the hospitals in the state of Michigan, including this fine institution, they all said, yeah, that's nice, we're not going to do it. I know all the doctors, I know everybody said they want to do it, we're not going to do it, okay? When we put $1 million on the table, the CFO told the CIO, I don't care what you want, get it done by the deadline, okay? I had a CIO, not this institute, another place, tell me, Tim, it'll be a cold day in Hades before we ever send you an ADT. And his CFO found out that all the other hospitals in the state were getting the incentive. And the way that the Blues incentives work is they put all the incentives in a big pot and they say, if one hospital does it, that one hospital gets the whole pot. If all the hospitals do it, then they divide the pot based on a formula. When that CFO found out that all his competitive hospitals were getting that pot, and he wasn't, the CIO had to call me 2 weeks before the deadline to have it done, and beg, literally beg for a slot to get in and get it done in time. And I said, oh yeah, we'd be happy to accommodate. But it is the biggest lesson I've learned is if you pay them, they come in droves. If you punish them, they come a little slower, a little less willing, but they still come. And it's really simple formula.
I think that works for ones where, there's someone like a health insurer or even the state willing to do it. For the ones, though, which are primarily and purely in the patient's interest, being able to not, fill out a form every time you visit someone out of network. How do you see making that happen?
Stick with us, I'll answer that.
So just to clarify, all these are a protocol of how information is changing, or actually actual policy change at the provider, or are there different levels? So
They're a kind of information that we want to share.
okay,
There's a legal component to it and a technical component, so eventually you get to a protocol,
right.
but this is a little bit higher level functionality capability. And I'll talk through a couple to describe them, but they sometimes require a process change organizationally to be able to make the data flow at a protocol level.
And how do you work with the EHR systems to make them bend as well?
HR systems kind of do what their customers tell them to do.
Kind of.
It's a great, well, they do if it's not too far outside the realm of what they can do, okay? And I've now gone through many battles with Epic and Cerner, and when you get to little ones like Meditech, it's a crappy piece of technology, so you won't be able ever to do anything. You'll just have to transition. But the Epics and the Cerners actually can share a lot of information, but their customers have to tell them to do it. It can't be anybody else telling them to do it. And once their customers have money on the line, they all collectively get on the phone with the leadership, because this is a real life story, and they say, we got a lot of money on the line, you're preventing us from doing this. And then I add a little bit of, hey, I'm going to send a report card of how well you all do this to the HIT Commission, so there'll be a little advertisement for it. And honestly, I have not found the EHR vendors to be there. But I'm also not in their space the way a traditional HIE is. Okay? So I'm not really competitive at our level with the EHR vendors, so they're a little easier to work with. So the best analogy I've been able to come up with for the way we handle use cases is the sort of traditional break bulk shipping. People were pretty organized in how they put all the information in, but it seemed to take a lot of hands and a lot of work to pull the different information out, or the different pieces out of for the shipping. And there was a lot of breakage. Some stuff got stolen. It was a big deal. Container shipping fundamentally changed that. And it didn't just change it because it put stuff in boxes. It changed it because those boxes got sealed and you couldn't get in anymore. And it changed it because there were just a set of rules where it got moved along in the system, however it was going to move, and it became very quick and very fast to sort of get it to everywhere else that it needed to be without a lot of handling, repacking, pulling up, retouching. And the way we're packaging these use cases is having the same kind of modularity effect. And it's more than a technical standard, because you are actually tying the legal pieces to this, as well as you are tying the financial incentives. So for example, instead of trying to have a bureaucrat in the state pull up the descriptions of a HL7 CCD and put in what the requirements are, they can say, you must support the statewide ADT use case. Okay? And it makes it way more modular. Go see these details someplace else for that. Or a health plan can say, you must submit your active care relationships as per the active care relationship use case. That packaging and simplification allows a policy maker to be able to say, what do you mean they don't support the opioid use case? Well, that's bad. They should do that. And they don't have to get into the battles of, is it FHIR, is it HL7 version 2, is it a CCDA, which by the time we've said even just a tiny bit of that conversation, we've lost the policymaker entirely. Okay? That's what I mean by the modularity and the packaging of the use cases. It's incorporating the social component along with the technical component in a way that allows the infrastructure to drive adoption of the technology.
If you pay a price for modularity, like putting stuff in container, who pay a price for this?
Absolutely. And I've got almost $1 million of legal bills to prove it. Okay? So yes. But on the flip side, you get the scalability with it, okay? And I want the scalability on a statewide basis. But you're right, you pay a little bit of cost, but you do for an IP packet, you know, modularity does cost you, but you get it back at scale. So I'm gonna walk you through an example of 3 use cases. Admit, discharge, and transfer, active care relationship, health directory. So, big problem is readmissions in the United States. We have about a 19% or 15% all-cause, depending on who you talk to. So, when you go into the hospital, they fix you up and they send you home, somewhere between 15 and 19% of the time, you gotta go back again. Okay? If it was your car, you'd be very dissatisfied. People aren't cars, it's not everybody's fault, but somewhere between 0 and 19%, there's a savings on stopping that readmission from occurring. And so part of the problem is that only about 27% of the time have physicians historically known that their patients actually went to the hospital and got discharged. And so you can intercept an HL7 admit, discharge, and transfer notifications, pretty standard message type, and you can send it out to the provider community to alert them that their patient has gone to the hospital, is standing in the emergency department, or has been sent home, okay? If they've been sent home, there's now a billing code. You go out and say, hey, I'd like to get you into the office within the next 7 days, because there's some evidence to suggest that if they do that, they can prevent a readmission. But they've got to know that you were in the hospital to actually call you and get you into the office and figure out what's going on. So in order to enable this, we have something in Michigan called an active care relationship. Some folks have historically thought of this as an attribution. It's a linkage between the patient and a primary care physician that just says, this patient and this doctor go together. And we get from the doctors these active care relationships, these linkages. And we get millions of them. And so doctors give us all their patient identifiers, first name, last name, date of birth, gender, zip code, last 4 their social security number, they have it. Links to the physician, all the identifiers for the physician, their endpoint information, like a direct secure message, a direct secure messaging address, or their FHIR endpoint, or their HIE, electronic service information, the practice unit, the patient-centered medical home, and then basically the affiliation group at the contracting entity or the physician organization. We get all this, we take this chunk of it at the bottom, and we put it in our health directory, so we have pretty current information coming every month. This is from July, we're up at about 11.5 million, but we get this every month. It's refreshed literally every month, all that information across the entire state. And then what we do with it is when somebody goes to the hospital or leaves the hospital or hits the emergency department and generates one of these admit, transfer, discharge messages, we look up in the active care relationship service, okay, which doctors have a relationship with this patient. And we usually get a list because people usually have more than one provider. We then look up in the health provider directory where to send it, how to send it, and then we deliver that information to the appropriate place through the appropriate vehicle. Okay? All right. So now one of the issues in this process is patient matching. Patient matching, if you're very restrictive, right, then you're going to miss a few people that you could have notified. And if you're not, then you're going to have a handful of false positives, which in healthcare is generally viewed as unsafe and risky. Okay? Probably with ADTs, it's okay, because you call them and go, hey, I hear you're in the hospital, and they go, no, I wasn't in the hospital. That's all right. But if you're making decisions around medications and some other kinds of things, that's a little more risky. So in Michigan, we've tried to come up with a fairly passive mechanism to improve matching across the state. And what we've done is we've come up with something called a common key service. And essentially, it's an additional identifier that we assign. We get all these 11 million acres every month. We actually bang them up against the state of Michigan's Master Person Index. They have about 17 million people in there. So we've got a pretty good pool to match against. We match them up and we assign a common key. It's a cryptographically signed number. It's not meant to be used for people. It's really meant for system-to-system communication. We assign that number. And a normal Master Person Index acts like a Rosetta Stone. You send in a medical record number and we match it up to what another health system calls that person. We use that medical record number and we send the patient information off on the other medical record number. Here it's a little different. It's almost an inversion of that. Here we're assigning this common key and we're asking all the different folks who send us active care relationships or ADTs to keep a copy of that key in their system, like a foreign ID. So we're pushing that magic number out, and it's an additional identifier when you look at the sort of golden record. You can use that common key to help you boost your match rate. Okay? Some of the Tiger teams have really recommended that we add an additional identifier. It's not a national provider, it's not the ID. You still use it with other things, but it boosts your matching rate. That's what it looks like. So it's clearly set up so that we're not having a person type it, right? It's meant for machine to machine. Okay? But what that does is it helps you create a brand new set of linkages that historically have been really hard. It's been really hard to know who is interacting with the patient on a broad basis. Okay? Now, this same process repeats really easily for lots of other use cases. You just replay the different parts in exactly the same way, and you just put different combinations together. And so we did this with ADTs, and we said, everybody just send them to the middle. We will clean them up, standardize them, and send them out to everyone so that it looks like just one hospital feed to everybody downstream. Okay? And then we'll use this active care relationships and the health provider directory boosted with the common key to send it wherever it needs to go. We're at 99.9% of all of the admissions in the state of Michigan come through this process.
So is this a use case, or is this a meta use case that's combined of 3 or 4?
ADT is a use case, Acres is a use case, Common Key is a use case, HPD is a use case. These are what we call infrastructure use cases,
Okay.
and then ADT would be a functional use case.
So when you go back to sort of your model of how you, I mean, it seems like, to get a financial model around acres, it requires it being paired with a lot of these other things. So when you're trying to do the incentives, is it for acres as a standalone, or is it for acres that's combined with the other pieces?
So hospitals get incentives to send ADTs.
Yeah.
Physicians, providers, community people get incentives to participate in active care relationships. They kind of want the ADTs. So you don't need to pay them to take the ADTs. But you need to pay the hospitals to send the ADTs to make them available. But you need to pay the doctors to do the ugly work of sending their active care relationships. So there's incentives for physicians and patients around the homes to send acres every month.
You're approaching this, I mean, you think about them in combination, even though they're sort of implemented.
It's a systems approach, right, to the different combinations to make soup, but we're brokering what does everybody want and what does everybody else need, because the hospital is really only interested in sending ADTs to the doctors they own. But if they're participating in the statewide ADT use case, legally it provides permission to send it to everyone with an active care relationship to that patient. And in that way it decouples the sort of legal endpoints and the control.
Any metric on what percentage of patient population you have acres for in the state?
We have 11 million active care relationships, and that boils down to about 7.3 unique individual patients.
What percentage of the population of the patient population in the state?
There's 10 million in the state.
So it's approaching 100%? Or?
It's at 75%.
75%. Oh, okay, 75%.
Okay. So now we've started with all the hospitals, and we're rolling out care summaries. And we're basically following a very similar approach where at the end of every discharge, and U of M is doing this, and most of the big hospitals are doing it, we're at about 70% of all the discharges. They have to send a care summary to us, but they have to fill out the problem list, the allergies, and the meds. And they have to fill out the meds that the patient had at the beginning, when they came in the door, and what they're now going out with. That's where the process change piece starts. And it has to be an RX norm. There's all kinds of other stuff in these big care summaries. We're not doing conformance testing on that. We're just doing conformance testing on this piece. They're sending us the whole thing, but we're kind of almost throwing it away and making them have the data be good in that piece. Next year, they're going to do the care plan and the pain plan to go with the meds. The year after that, they'll do all the diagnostics and cleaning up all the tests that were done, and the year after that, the advanced correctives. Okay? So that we can systematically clean up these big monolithic documents. MedRec is now working the exact same way. So everybody sends from all the hospitals, we're about 75%. The incentive payments are due at the end of December, so my guess is we'll get up to about 90% when that payment comes due. Miraculously, the tech will align. Okay? Follows really the same process as ADTs. Okay? So what we're really doing over the next year is setting up the incentives for the ambulatory space. So we're going to ask all the patient-centered medical homes, every time you visit with a patient, send your care summary, just like the hospitals are doing for their med recs. It's kind of the Federal Express model of send it all at one spot, we'll resort it and redistribute it every place it needs to go. Okay? That will continue to expand. We're doing the same thing with pharmacies. And we're starting to look with the state innovation model at various community services where it's pretty much, you don't really think about it, there's not much of a cognitive burden. Package it up in a standard, well-known format, send it here, and based on active care relationships, we'll redistribute it where it needs to go. Okay? So what we're doing for the master data is we're really trying to link the care coordination use cases, that's the doctors kind of taking care of people because there's lots of people touching the patient, to the quality measurement process, that's really how people get paid. And historically, these have been two big stovepipes that really have had very little in common. And we're trying to build the health directory and the active care relationship service as a mechanism to link these two. And we built all that in Salesforce. Those of you familiar with platform as a service. Salesforce is the platform we've used for that. And what we're finding is we're also now being forced to build out tools to track which doctors are in a patient-centered medical home, which doctors are in an advanced payment model, which doctors are sending their information into the state immunization registry, so that it's become a workflow management of how to keep track of who's at what stage of their evolution, including who's signed up for meaningful use or not. And we have another activity I'm not going to talk about today in the state called the Statewide Consumer Directory. But there's a whole bunch of tools about to be rolled out to consumers to let them manage their preferences. So everything from consent to contest and active care relationships to route your data to one of these consumer qualified organizations. We've been focused on burdens. Quality measures are the famous burden on doctors. When you graph all the quality measurement programs, and there are many, and there are literally hundreds of quality measures, and you do a Venn diagram, there are only 3 quality measures that are consistent across all of those quality measurement programs. And they're getting better because Meaningful Use does this one up here for electronic clinical quality measures, and the latest program, CPC Plus, actually uses those same electronic clinical quality measures. So there's an alignment starting to happen. But unfortunately, all the health plans ask you to send that information, even those 3 measures, in entirely different ways. And so now that we have all the health plans organized, we've got them beginning to send all that information in a consistent way, so they can do what we call report once. Under report once, a physician organization can just send one big file of their supplemental clinical information. They'll send it to us, we'll use the active care relationships because we're now getting the enrollment files and the active care relationships from all the health plans to break it apart and deliver to all the health plans basically the data. And the doctor's office only has to pay for one interface as opposed to at least 27 for each of the different plans. Okay? Makes a pretty big difference, but what's interesting is we've really been able to convince the health plans that what they need to standardize is how they send back the gaps in care report. Because right now they've been sending back Excel files or a paper document or a fax or a PDF. It's been horrible. And we're trying to get them to try to treat closing the gap in care like it's a transaction. And what's interesting under an advanced payment model is in the past, people were very parochial about owning this relationship with the health plan. But now, when they get sort of a shared savings to just make sure all the gaps in care are closed, an opportunity opens up to say, well, how about if we take this gap in care and we send it to everybody that's got an active care relationship with the patient and say, hey, can you guys help us close this gap? And the gaps get closed. Okay, because a lot of times it's just been historically missing the information. It's kind of a different way to think of it. So, where we're headed in the state of Michigan as ADTs and regular active care relationships from everybody. So hospitals and facilities send ADTs, everybody else sends their active care relationships. Care summaries, all the labs, in this month they're starting to send all their labs. We're going to take the labs, stuff them into a care summary, so doctors only need to know how to receive a care summary. And then we'll start receiving these electronic clinical quality measures once a month from folks, and those are part of certified EHRs, so they can send to Category 1. And it will greatly simplify what people have to do to sort of participate in a larger data sharing initiative. We will continue to expand the active care relationships. Those of you who are kind of into a NoSQL kind of world, it's a very simple data structure that you can begin to process very, very quickly. And it starts to give you a mechanism to say, okay, who is interesting that I need to go and reach out to? And we're beginning to collect more and more of these active care relationships from everybody who's kind of touching the patient, okay? Including research programs that patients have opted into, so that we can basically start forking off information to a research program or a clinical trial that a patient has said, yes, I want to be part of. Okay? It creates a pretty ubiquitous way to have that same process send information automatically to a program. So the last piece that we probably have time for is we standardize the flow of information, and we start getting a lot of active care relationships that if somebody's just on a high utilizer list, it's an important flag. We can then take that and start to append information to these messages that might be relevant. It could be everything from a URL for where to go get information to a flag that says if you care about someone who's a high utilizer, maybe you want to look at this message first versus somebody who isn't. Okay? The second thing that we're starting to do, particularly around looking at medication portfolios, is these screens or filters. Some people might call this a predictive model, but it doesn't have to be that sophisticated. And we would actually begin to route or handle the information differently based on the screen. It's looking at the content. Maybe the problem list looks a certain way. Maybe the combination of meds makes it high risk. We would treat it differently. We could even score the data and append the score to the back of the message itself so that it can get triaged in a different way. And so this is what we're starting in the spring. The last piece here is many people are advocating for building a big longitudinal health record. I think that's probably premature. I think you build this active care relationship infrastructure, and as FHIR and query type capabilities exist in all the EHRs, which are at a pretty nascent stage right now, okay? You push the data to everywhere for a while. As soon as query becomes capable, you can use this active care relationship infrastructure to say, who has had a relationship with this patient? And I will use that as this very smart record locator infrastructure to then go and selectively query all the places that have that information, and I can on demand pull what I need back that could have a very longitudinal flavor for that particular patient. And as time marches forward, most of these systems get better and better at making that kind of information available. So I'll stop there. Comments or questions?
Thanks, speaker.
Seems like so you trust the provider to provide the active care relationship. Where does the patient fit into this in terms of, I can imagine cases where a patient might contest whether there's an active care.
So we have this consumer qualified organization. They're basically, the release will happen in January of an SDK, software development kit, for consumers. They can either go in payer portals or it'll go into consumer qualified organization portals to interact with the statewide consumer directory. And what it'll do is it'll surface your active care relationships, but and you can contest them. But what you can't do is break them unilaterally, because you've given consent in most cases to those providers, even though you don't know you have, or you've signed away a lot of things. And so what we're trying to force with Acres is a dialogue where you go in and consent it, and contest it. We surface that back to who gave it to us and say, patient contested this. We'll also offer the ability for the patient to make a request to add somebody, but doctors may contest that that's not really their patient as well. So there's a whole process that hasn't hit here for patients to sort of intervene. But honestly, under HIPAA and under the standard practices for what people have consented to care, they've consented to care coordination.
Well, in theory, right? I mean, you can
No,
imagine.
under HIPAA.
No, I mean, you can imagine cases where, for nefarious reasons, a doctor may, even if consents to withdraw on it, I mean, we can imagine some downstream risks that are pretty serious.
Absolutely, and people putting in a famous person, right, and saying, oh, I'm taking care of this famous person, and having their data automatically routed. So we've got these filters and things to look for special oddities, okay? But we also think there'll be a need for people to opt out of care coordination altogether. But we're going to basically require them to, when we opt out, we're going to tell everybody who submitted an active care relationship for that person that this individual has opted out of care coordination. You may want to talk to your patient because there's some value in it.
So can I ask about scaling this to other states, I mean, it seems like this is great if you live in Michigan, but then what if you're getting care?
So MiHIN is under contract to sort of roll out the Michigan model in New Jersey. And they're a few years behind, but I think they're headed this way. Okay. We've been interacting with a handful of other states in Arkansas, Oregon. We'll see. Different states have their own legacies in these things. Most of this HIE stuff has been an unmitigated disaster and painful for states.
When you build in New Jersey, are you building the ability for these use cases to be seamless? Should someone from Michigan go to New Jersey? So I mean, are you sort of, or is it really going to still be sort of contained in the state boundaries?
There's an opportunity. They're not ready for that, but there'll be a very, very real opportunity for them to basically say, oh look, this is a person who's showing up with a Michigan address, to send it over. And even, HIEs are across the country are already doing this with each other, where we're able to say, oh, I'm going to send it to a place in Michigan, and they'll be able to process it. Okay, but it'll work the exact same way, where the follow-up endpoint information will be available from the field to go back and look for the detailed data. The issue that will happen is who's authoritative in a given state hasn't been resolved. And so that is a set of bilateral agreements and across different HIEs. And many states have multiple HIEs that fight. And so they might say, well, this HIE and that HIE want to work together, so that's who we send it to in that state. That hasn't been resolved. And that's going to take a little while to get resolved.
What about at the patient side? Say these advanced sensors like the health kit in an iPhone. How does that come into this picture of information sharing?
We just started so in Michigan, we haven't deployed statewide electronic consent and the statewide consumer directory. And we just started talking to the Apple folks about, okay, Apple doesn't really have in its vision right now a jurisdictional body like MiHIN being involved. It's really just a pure consumer kind of play, and an institution kind of level or a vendor level like Apple and Epic might work together. They don't yet have in their framework an idea that there's a jurisdictional entity like MiHIN. And so we're working with them to figure out, do you want one? What role would it play? Because done right, it would actually provide some guardrails for everybody. But that's not historically how Apple has gone about doing things. You know, they've been sort of anti-man, right? And so I don't know how that would play out.
But in a perfect world, how would that look?
In a perfect world, in our world that
Right.
we're designing, basically Apple would have a set of options where, as this data is going by, because we're now creating this hub, this Federal Express model, it's all coming to the middle, okay? A patient would go in and establish active care links to things where the patient wants information to go, one of which would be an Apple solution or any patient-mediated place. And what we've created is a really simple switch point for that data to all flow there. So we think we've got a nice collection point to get all of the data that's flowing about a patient to go to something like an Apple solution. Okay, so there's a nice control point once all the data is reached critical.
So is the information connectivity going higher and higher? So the risk of having like massive, data leak, or attack is also goes higher and higher. So what kind of measures have you put in place to prevent catastrophic events?
We've got so many of them. But so the latest denial service attack on Amazon, a lot of our world is in Amazon. We still provide and pay for a complete virtual private network overlay. So all those trusted entities, even though they might be using all kinds of standard protocols, are still operating like one big private network, okay? And that saved us from this most recent denial of service attack. We have armies of monitoring and all those kinds of things are going on. But the other thing is, part of the reason I'm personally not trying to have our organization archive this information and have a longitudinal medical record, because I think it is extremely risky. And so my model is, let's do what we can to know the minimum amount, that's how everybody's connected and where to go get the information, and enable an infrastructure so you go all the way back to the edge and get it. And we think that's probably more secure than taking a copy, putting it in the middle of everything that's ever happened. But that's my opinion. That's not necessarily current risk.
So we're a little bit after 1 o'clock, so I want to make sure folks who have to
Please
go
leave.
get a chance. So,
Thank you very much.
yeah, thanks again.